As usual, you start, when you talk about any organ, we start talking about non-neoplastic lesion, medical lesion, congenital disease, and then in the second lab, we'll take the tumor and neoplastic lesion. So we'll start talking about the hereditary lesion, or example of non-neoplastic lesion. We'll talk about cyst, kidney cyst. We have different causes of cyst. We have a hereditary cause, and we have a, for example, cyst associated with dialysis, long duration dialysis, or an incidental single cyst seen usually in adults. So in cases of hereditary, as you know, we have what's known as polycystic kidney disease. We have two types. We have two types, recessive and dominant type, autosomal dominant type. Usually the recessive type, you see it in early, in infancy, and the dominant type, you see it usually in adult. Okay? So we'll show you a picture of each grossly. This is the first one, autosomal recessive type. You see it in an infant. We have an enlarged liver, and we have bilateral enlargement of kidney. So the kidney size is supposed to be less than half of this one. So as you can see, we have bilateral enlargement. So if we took one kidney and by half this kidney, if you remember the normal anatomy of the kidney, we have cortex, we have medulla, we have the urinary pelvis. So as you can see, it's completely replaced by cyst formation, quite small cyst formation, evenly distributed through the kidney. If we see it under the microscope, what we'll see, the normal histology is completely replaced by cyst formation. They are elongated around the center, so it looks like a cartwheel. This is the radiation of the cyst, and here we have the central cyst. So as you can see, there is a remnant of glomeruli. So this is a typical example of autosomal recessive type. Sometimes these associated with liver disease and with pancreas. So what do you expect to see within the liver if you have an autosomal recessive polycystic kidney disease? This is the example. We have a congenital hepatic fibrosis. What do we see? This is the portal tract, and usually you see artery, veins, and the bile duct, one or two bile ducts. But as you can see here, we have a proliferation of these bile ducts at the periphery. When we have dense fibrosis, this material in between, it's a fibrosis. So you expect to see fibrous, but not that much, okay? The other example is the autosomal dominant polycystic kidney disease. So here we have bilateral enlargement of kidney, and usually if it is bilateral, then it is here in hereditary causes. So we have bilateral enlargement, and it's better seen in this photo. Here we have, this is the kidney. Here it's opened kidney, and here we have the transplanted one. This is the normal size. So if you compare it with this is very big. So we have enlarged kidney, and it's replaced by variable size cysts. So these all are cyst formation, variable in size. And this is another example. You can see here all these cyst formation are variable. Here we have large one, smaller one, completely affecting the whole kidney. And as I said, it's appear later in adult life, the autosomal dominant type. As I said, we have another example of a cyst formation. As you can see here, it's associated with a renal dialysis. So if the patient have renal failure and in a long duration use of dialysis, it will form a cyst associated with long duration dialysis. Here another example of cystic changes seen also in dialysis, but it really also, as mentioned here, give what renal cell carcinoma. So here we have these at the periphery. This is the cyst, and at the center here we have a fair heterogeneous tumor. We have yellow area, brown area. So this is an example of a tumor. It's a carcinoma, and commonly it's renal cell carcinoma. Another form of cyst, as I mentioned, simple renal cyst, seen sometimes incidentally in old age, can be seen at the surface, as you can see it here. So now we'll talk about the medical lesion that affect the kidney. The important that I'm sure you know, it's glomerulonephritis. From the name, that means the disease affecting mainly the glomeruli. The glomerulus is a connection between the tubules, the nephron, and the the vessels. So at these, both are meet, they called glomeruli. So we should know the normal histology of the glomerulus. Here we have, this is the glomerulus surrounded by tubule. So the important thing here, we have the capillary lumen. It should be patent, as you can see here, it's empty, patent. We have the endothelial cell here, and there is a basement membrane. And in between, or not in between, let me say, covering the capillary lumen at the basement side, basement membrane side, the podocyte. And in between we have the mesangial matrix and the mesangial cell. So the very important thing that the lumen is patent, you can see clear spaces, this is very important, you will see it in the coming picture. And we don't have the proliferation of endothelial cell. So if there is a proliferation, the lumen will be obstructed, okay? And if in between, as I said, we have the mesangial cell. This is the mesangial cell in between, and this is the matrix. So the mesangial usually from 2 to 4 number. If we have mesangial proliferation, it will be more than 4 of mesangial cell. So if the deposition of immune complex, for example, within the basement membrane, you will see proliferation, for example, of endothelial, and it's obstruct the lumen. If we have the deposition within the mesangium, what you will see? Mesangial proliferation. So in any kidney biopsy, we have to examine it under the light microscope. Then we have a biopsy for immunofluorescence and another one for electron microscope. The one for the light microscope, usually we use an H&E staining, and we use also a special stain like PAS, Masson trichome, to highlight lesions. So here in the second picture here we have the PAS, which is a special stain. It's very helpful when we have an expansion of mesangial, for example, and thickening of the basement membrane. It will be better seen by using the PAS. So also this is a normal picture. We have an empty here spaces. We don't have a capsule. Here we have the capillary lumens are patent. We don't have a proliferation of any cell. So this is very important diagram. Here we have, as I said, the capillary lumen. They are empty, as you can see, and it's lined by endothelial cell. And we have here the fenestration, which is very clear. And then it's covered or lined by podocyte. This podocyte having a food process, as you can see it here. This is very important when you examine it under the electron microscope. And we have in between the mesangial cells, and this is the matrix. So the first disease that we'll talk about, as you know, the kidney lesion we divide it to nephrotic and nephritic. In case of nephrotic, usually there's a protein, losing of protein, so we have proteinuria, edema. In cases of nephritic, we have hematuria, that we have blood within the urine, and hypertension. Then each different glomerulonephritis lead to one, and there is sometimes overlapping between both. So the first example of nephrotic, that means we have losing of protein through the urine, we have proteinuria. It's minimal change disease. You will see it usually in children. So children with nephrotic syndrome, you will think about minimal change, then membranous. And we'll talk about membranous later. So what do we see in minimal change disease? We have, as you can see here, this is the RBCs, this is the capillary lumen, this is the fenestration that I mentioned, and this is the basement membrane, and this is supposed to be the podocyte. And as you can see, we cannot identify the normal food process. As if compare it with this diagram, this is the food process that I've talked about. Here, it's completely effaced. So effacement of this food process lead to losing of protein, okay? So this is typical. Usually in light microscope, it's normal. You don't see any changes, but you see the changes through the electron microscope. Another example of nephrotic, focal segmental glomerulosclerosis. What do we mean by focal? Focal, if we less than 50% of the glomeruli that you examine in the biopsy is affected by a disease. And segmental, the same glomeruli, each glomeruli, for example, this one, less than 50% affected by a lesion. Glomerulosclerosis, why we said sclerosis? Because there is a sclerosis within the glomeruli, which is deposition or collagen within disturbing the normal architecture. So here we have, as you can see here, this is the normal side. Here we have abnormal things happening, which is sclerosis. It's less than 50%, so we call it segmental. So we use